Hello, my name is Bill Rodriguez. I'm the CEO at Find here in Geneva, and I'm joined here today by Kara Hansen. Kara, would you like to introduce yourself?
Sure, thanks, Bill. I'm Cara Hansen. I'm Professor of Health System Economics at the London School of Hygiene and Tropical Medicine, and I chaired the recent Lancet Global Health Commission on Financing Primary Healthcare.
Excellent. Thank you for joining me and for joining us here today. As you know, this coffee chat, is part of the Global Week for Action on Non-Communicable Diseases. We're here today really to discuss sustainable financing for NCDs and to reflect on some of the differences between NCDs and infectious diseases, and from our perspective, the critical role of diagnostics. And so this is part of a series to explore multiple facets of diagnostics for non-communicable diseases in low and middle income countries. And it's part of the launch of Find's new program in NCDs. So thank you again for joining us. Before we really get into the meat of that discussion, I actually just want to start by asking you a bigger picture question. You've been working on sustainable financing in health for close to 20 years. And I'm just curious to know whether you're more optimistic than you've ever been, more pessimistic than you've ever been, or what your view is on where we are with compelling sustainable mechanisms for financing for primary healthcare in LMICs broadly, not just NCDs and diagnostics.
So, Bill, I think I'm both optimistic and pessimistic. It's a tricky time to be asking that question. So, I think we're all very aware of the fiscal crisis that COVID-19 has led to, both in low and middle income countries, but also in high income countries, and affecting aid budgets as well. And so, in terms of the kind of the short term, prospects for really increasing health spending, I think it's really challenging. On the other hand, I think the pandemic really showed us the absolutely vital importance of having a strong basic health system in place as a way of both kind of managing the response to the pandemic, but also in sustaining access to other interventions during the pandemic. And so this is a great moment to be trying to really influence and persuade governments that they need to spend more on health, they need to spend more on primary health care. And I think what we did in the Lancet Commission was also to show how to spend better on primary health care as well.
You know, what's interesting is when you just look at diagnostics, right? I think what we've seen under COVID is this mixed impact, right? It's had a massively negative impact on a whole bunch of things, ranging from economies to individuals' lives and communities. But it's like no other disease before it. It's highlighted the importance of testing. We never used to have the kind of traction about, hey, testing is essential to basic health services, the way we've seen it come out of the COVID pandemic. And that's put Find in a new position to be able to influence the agenda around primary healthcare. But also we recognize there's a long way to go. So now I'm asking you for advice. How do we do that? So let me go back 20 years of vertical programs on HIV and TB and malaria that include testing. Do we leverage those directly? Did we learn that that's the right way to do things when we're talking about NCDs and primary healthcare? Are there lessons that we need to take and do it differently? What would you say to what's in place for those big infectious diseases, and how we think about having to shift now to focusing on primary healthcare-based care for NCDs?
Yeah. So I guess what's interesting about those vertical programs is that they brought an awful lot of money, and they brought an awful lot of, I guess, focus to some of those key infectious disease programs. But I think they've created an awful lot of problems as well in terms of the fragmentation of the funding of the health system, but also fragmentation of delivery platforms as well, having parallel systems for drugs and supplies, parallel systems for information, and parallel systems for sending money through the health systems as well. So I really wouldn't want to see a new vertical program for NCDs. I'd really like to see us challenging governments to include funding for NCDs in the funding of the health system, and thinking about how we can use a mission of comprehensive access to an essential package of care as the mechanism for funding NCDs better.
We're facing the same tension on how to leverage those old programs, because in point of fact, as I hinted at with COVID, HIV and TB and malaria really drove a sweeping transformation of how testing is done in a way that just wasn't the case, including at the primary care level. We have rapid tests now for HIV that we've also applied to COVID. So we have to navigate these, pretty tricky balances between, we've got a great laboratory infrastructure set up to test for these infectious diseases, how do we leverage that to shift the approach and the model so it's much more focused on a comprehensive primary healthcare
Mm,
uh, and the services we need to support that from a testing perspective. And I think
yeah.
that's our future.
Yeah, that's right. And then, so one of the ways that we've thought about financing in the commission is about how to ensure that enough resources are channeled for PHC, and that they're channeled through to those frontline providers. So I would say kind of two things there. So one is we do need to make sure that as countries' fiscal capacity increases, that those that testing and management of NCDs is included in benefit packages. And we see countries trying to do that. We see, in Kenya, for example, their national health insurance scheme has a new NCD benefit package that people have access to. So uh, funding those services is really important. But the other is making sure that the money reaches the primary care level, and that's challenging in lots of different ways. We often think about the budget as the way that money reaches the primary care level, but there's other things as well that are important. And I would say one of them is this issue of where is the testing capacity. So there are important decisions about the location of infrastructure that have an enormous influence on where the money gets to. If you choose to locate your testing infrastructure at the hospital level, that's where people will go and that's where the money will stay. If it's possible to shift that testing infrastructure to the periphery and making sure it's really at the primary healthcare level, and that's another way of getting resources to PHC.
Yeah, I 100% agree. And we saw that under COVID, right? A lot of the early effort and really all the way through now, mid 2022, a lot of the investment in COVID testing was molecular testing in laboratories, right? You'd go to a clinic or a provider or a stand-up COVID center and you'd say, I don't feel well. And they'd say, go to the COVID testing center. They're going to take a sample and in a couple of days, we'll tell you your result.
Mm-hmm.
And that's not the model for primary healthcare, right? That's exactly the wrong model. What we did see under COVID was relying on rapid tests, pushing self-testing, right? That we do routinely now for COVID in high-income countries, but has not really been yet available widely in LMICs. That's certainly a way that you can increase access at the primary healthcare level for other conditions, including NCDs. And we need to learn those lessons, hopefully not more than 5 or 6 times before we get them right. But let me ask you something about this fiscal capacity that you've raised. So it's a question about what's the appropriate role of the donor community. If really the issue is we want to make sure these are programs that are sustainably financed from fiscal capacity, how do we get there, broadly for primary healthcare, and how do we make sure it covers the right set of services, including testing services for infectious and NCDs?
Yeah, well, I think that is the question, isn't it? So how much can governments spend, and how do we make sure that they do spend? So, clearly in low income settings, just the levels of fiscal capacity are far from sufficient to support a comprehensive package, even of basic, primary health care. So there, I think there's a continued really important role for aid, but important for donors to think about how they spend their funds to make sure that they're not contributing to fragmentation of the health system, but are really helping to really generate and sustain a kind of a fairly a well-aligned and strategic set of funding streams. In lower middle income countries and in upper middle income countries where fiscal capacity is greater, then we really do need to be persuading governments to spend more on health, and persuading them that that spending more on PHC is going to give them the best bang for their buck. And that brings also issues of stakeholders and stakeholder management, doesn't it? Because it's not the Ministry of Health's choice how much to spend on health. We have to be persuading finance ministries in the first instance that that spending on health and spending on NCDs is an important economic investment as well as one in well-being. But then within the Ministry of Health, that's where the decisions are made about where to spend, and really focusing the resources on the primary healthcare level, I think, is a way to make sure that NCDs are well managed as well.
Yeah, you bring up so many key points in that one comment. So first, I would say I think we're guilty at FIND, and I think in a lot of agencies, of thinking of LMICs as this one uniform group of settings and countries that lack access, when obviously they all have their own challenges and issues and diseases and approaches and infrastructure and human capacity. And it'll be new for us to really think of how do we engage with each country on its national agenda, making sure that there's a uniform set of tests and tools that can be applied to diabetes, cancer, cardiovascular disease, chronic illness broadly, but is going to have a different role and a different setting and a different prioritization based on each country's own national agenda. So we have to figure out how to do that. And then the second thing is it's really about the private sector, right? So I think we need to figure out, as care gets in a lot of parts of the world, from what I see, care is being stratified. There's a growing, emerging middle income class across many of these countries that are demanding services outside of the public health system, right? And then the private sector is responding with, new clinical care, chains, pharmacies that deliver care, independent testing centers. Traditionally, we haven't engaged with that sort of private sector health system directly. We've gone through government, but I think it's going to be critical. However, as I think you and I have talked about in the past, then you're stratifying populations in countries like the wealthier communities get some services and the poor get other services. How do you balance that? And I don't know if you have a sense of how we do that, but I'd love your thoughts on that.
Well, I think one issue is that the private sector is not just being used by that middle class, that even low-income groups are spending enormous amounts of money out of pocket. And if you look at kind of the expenditure profile in low-income countries, 4 times more is spent out of pocket on primary health care than governments are spending. So we're talking about $3 per capita of public funds and about $12 per capita out of pocket. And an awful lot of that money is being spent on medicines. So I think really getting to grips with how do we make sure that primary health care benefit packages include ways of accessing medicines is vital. And I suspect that you would say also diagnostics, because obviously the diagnostics is the pathway to access to medicine. And so there's the money side, and these significant use of the private sector, which exposes households to all kinds of risk. And it is kind of interesting that as some governments have looked towards creating coverage schemes, I'll say insurance schemes. I don't mean just insurance. I mean they can be tax-funded coverage schemes as well. That some countries have said, oh, our priority is protecting households from hospital-level care because that's where catastrophic expenditure takes place. But there's lots of evidence that the kind of frequent use of primary care services also can be impoverishing to households. And that's really driven by issues of chronic conditions, right? Where people have to visit providers regularly and use medicines in a lifelong way.
Yeah, and we, everything you said about medicines and care services is true for testing, right? We know full well that patients will go to the public sector to get evaluated. Then they'll be told, okay, go get these tests. And we don't pay for them here. We don't cover them in the public sector. Then they go to a private provider. Then they have to come back and meet with the public health sector again. And there's 2 challenges. One is just the day-to-day. It's so much stress. They've got to leave work or get childcare. They're doing all the work, as you say. And then 2, the information is completely lost, right? It's their responsibility to maintain the information. So that brings up the obvious question of what's the role of digital health and digital tools? Can we use that in a way that actually doesn't make that problem worse, but actually helps solve that problem of putting the burden on patients? What's your experience and your sense of that?
Well, my sense is there's an awful lot of hype about digital solutions, and there's every week you read about a new app that allows people to manage their own care, to get their tests and diagnostics and control all their data in their own phones. And I have to say that worries me profoundly from a care coordination point of view. But also, these apps are often being used as financing tools as well. So ways to have, sometimes they're called digital wallets, which are ways to save money for healthcare costs. And that just undermines the whole point of pooling, right? Pooling of resources across populations is about solidarity and about enabling cross-subsidy between people who are sick and people who are not sick. So I think these apps on the financing side are quite worrying from a universal health coverage perspective. But even on the care side, I suppose I would rather see technologies being used to support professionals in helping their patients to manage their care rather than kind of devolving responsibility for that.
I can agree more. I think we have seen some success I'll talk about diabetes, where I think it's been probably the most widely used across sub-Saharan Africa, India, some of these patient-facing apps that are on their mobile phones are really about education, right? It's about inform yourself of what you need to do, what symptoms to look for, how to manage your illness, resources, tools. And I think that's a great use of digital technology. But once it slips over into financing or money or managing your own care clinically, I agree, we've put the burden in the wrong place. And I do see some of the real wins just where you say they are, which is let's use digital tools for provider to provider communication, right? Let's make sure they have a way to coordinate care and share information across primary healthcare systems and services, testing services, pharmacies. So, and it's a holy grail in every country to be able to have that kind of integrated system. But given that how important it is and how essential it is for patients to have that kind of infrastructure behind them in these settings, I think that's where the real value in the near term is for digital health. And I agree, we haven't yet lived up to the hype, right? And we need to. And I think diabetes is a really good example of a disease where if we're really thoughtful and careful about the digital tools that are applied and used, we can really help patients get access to care, manage their disease on a daily basis. But we have to do it in the right way that doesn't create a bigger problem for them. It actually solves that problem.
I think at all costs, we want to avoid further fragmentation. There's already an awful lot of fragmentation in health systems. There's all these different flows of money that come from donors and from government and out-of-pocket payments. And I think finding ways that will kind of align resources around a clear set of strategic objectives, I think is really important.
Yeah. Do you think we are in a position now through existing financing mechanisms, national budgets, ministries of finance working with MOH on their priorities, global programs that support some pieces of this, to really tackle diabetes? Do we have the financing in place for the initial screening, the staging of where they are in their disease and diagnosis, the routine care, including eye care, foot care, and all the tests we need on a regular basis, and then the right medications? Can we do that? Is that something that countries that you're working with or groups that are focused on diabetes care, can we really set up comprehensive diabetes care in many countries through existing financing mechanisms?
I'm just looking at a figure on my other screen here. So at the moment, low-income countries are spending $3 per capita government spending on PHC. You can't get much of anything for that. Mm-hmm. And even lower middle-income countries are spending $16 per capita. So those figures are so far away from any price tag exercise, right? We didn't want to come up with a new PHC price tag in our commission, but it's going to be somewhere between $50 and $80 or $90. So these countries spending is really far away, and even if you double that, which is going to be particularly challenging in the short to middle term because of the other fiscal and growth issues, I think it's going to be very challenging to expand benefit packages significantly.
So I think there's 2 points I'd love your thoughts on. One is we're well aware of those numbers, and that often is why testing gets marginalized, because with such a limited budget, they say, well, we need to focus on medications and vaccines at least, and if there's room left over, we can test, but there's not a lot of room left over. So that's part of the challenge, is now that people are aware of how critical testing is broadly, you have to factor that into the constrained budgets and what the value and role is. And it's on us to kind of define what is the value of testing in different disease areas. But then the second point, which we've discussed a little bit before, is, well, then you need to pool that money into some risk pool, right? And I'm wondering if you think that we're at that point now where national health insurance schemes are going to be able to do that broadly for their populations, or what the right approach is, so that we can begin to acknowledge we have limited funds. Let's figure out how best to use them broadly across an entire population instead of relying on people to spend out of pocket.
I think increasing the coverage of those approaches, I'm hesitant to call them schemes. I'll tell you one in a second. I think that's got to be the way forward. It's drawing in, bigger and bigger pools of people, and then getting contributions. And those contributions can be in the form of insurance contributions, or they can be in the form of governments allocating tax revenue, right? Sometimes there's a view that people have to contribute. people do contribute through the tax system to the public services, and using tax-funded systems has been a tried and tested way in some of the more successful systems in Southeast Asia, for example. So in Thailand, the universal coverage scheme it's not an insurance scheme. It's actually funded by tax revenue, on the understanding that everybody pays in a fair and proportionate way through their taxes. So absolutely, I think the way to go is to try to increase the coverage of these systems, to put more money through them, and to use that as a way of really reducing the exposure of households to out-of-pocket payments.
As you know, the theme for this year's Global Week for Action on NCDs is invest to protect, and I think that's exactly what Thailand, and others are doing, and we need to figure out how those approaches can be applied, broadly in many countries. So, and I think for us, on the diagnostic side, getting back to the part of the conversation we talked about, what's the role of overseas development agency support, and what are the concerns that they can help fund. We need these long-term financing mechanisms to be locally owned, but we do need a lot of investment in kicking things off. We need the right tools that can fit inside the context of those approaches. We need to understand, what is the priority? Is it hypertension? Is it diabetes? Is it a handful of chronic illnesses that are playing an outsized role in people's lives? And make sure we're getting the support to build the right tools, including digital tools that can be used to manage, to coordinate care. And that's our challenge, I think, at Find. And as we launch our NCD program broadly, we need to not try to boil the ocean, right? We need to make sure we understand what are the national priorities in these different settings, and how can we make sure the R&D and tool development and system development agenda is aligned with that. Otherwise, we're never going to be able to make progress.
Yeah, no, I think that's absolutely right. So I think that for the global donor agencies, first, do no harm. So contribute in ways that help to sustain rather than fragment the system, and to make it more aligned around strategic priorities. And then I think you use the phrase, "It's up to you." It is up to you guys to find those inexpensive technologies that can be deployed at the primary healthcare level to keep those resources and people at the PHC level that can be used to support people in the management of their own disease.
Yeah. And I'll let you go in a second. We can wrap this up, but I'll just say it's a little early yet, but the exciting moment in testing is we are on the cusp of a new wave of technologies that are designed for these settings for primary healthcare, where patients can come in with symptoms and they can get their disease diagnosed in a simple test across a range of multiple diseases. It's not go to the COVID testing site or the TB testing site, or we don't test for these things. We have equipment and tools that we can use in primary healthcare settings to say, oh, you've got respiratory ailments. Well, let's look at which of these 25 things it can be, and for a few dollars, we'll give you an answer. There's still money that's required, right? You still need to fund that, both the initial investment in those technologies and getting them implemented, and then the ongoing recurring costs of the tests. But there is a new wave of technologies that we think we need to make sure everyone has access to these, right? That they're not just limited to a select part of the global population that can afford them, for some definition of afford.
And by developing technologies that can be deployed at that PHC level, you're on the first step to that. So that is absolutely essential.
Yeah, that maybe brings us full circle to our initial question. The initial questions I asked you about, are you pessimistic or optimistic, and what can we learn from these infectious disease-based programs? From my perspective, I'm hugely optimistic. It's challenging, but we have the opportunity. One, we learned really from HIV, but also the other investments, that when you invest in longitudinal care for adults who are sick, it pays off, right? You can, as long as you help them maintain good health, they become productive school teachers, nurses, workers, parents, and it builds your economy, right? And I think that's a lesson that HIV kind of revealed. And then COVID just sort of blew that up. We've seen now that if you don't invest in basic healthcare services, pandemics as one component of that, boy, economies and people really suffer. And so I'm optimistic that the political moment that's been opened up by COVID, and the recognition of the stakes involved if you don't invest in healthcare, I think makes me very optimistic that we can make enormous progress, as long as we can, as you say, build the right coalitions, make sure it's informed by what patients and providers really need, and driven by a local prioritized agenda. So Great. Thank you very much, Kara. Really appreciate the time today and look forward to continuing this conversation with you.
Me too. Thank you very much for the opportunity.